Thanks. It's a pleasure for me to be here with all of you. I'm going to provide you with an overview of the Iridex clinical program and an update on our clinical trial that we refer to as NEAT. So our technology we call autologous intracellular drug encapsulation, which is a really complicated way of saying we take otherwise toxic drugs and literally hide them into red blood cells so that we can deliver it in a way that is less toxic than when it's delivered in its traditional form. So this is the machine to the right that does all of this. It's called the red cell loader, and it's about the size of an old desktop computer. And through an automated system, it basically does that work. And this is how the system works. We draw 50 cc's of blood from the patient, and then the red blood cell opens through this machine that I just showed you. We put dexamethasone into the red blood cell, then another solution closes the red blood cell. We re-administer it to the patient, and then the drug, which is dexamethasone, a steroid, otherwise relatively toxic when administered in its regular form, is administered to the patient and slowly released in the bloodstream over the course of the red blood cell, which is about 21 to 28 days. And we find that this significantly reduces the toxicity of that drug. So yesterday I gave a talk at the scientific conference about the pharmacokinetics of the way that we deliver dexamethasone through the red blood cell versus the way that it's administered traditionally, either through an IV or a pill. And it's really pretty complicated. In fact, so complicated for us as somebody that develops drugs for a living, we had to bring the world's expert of steroid pharmacokinetics to teach us how the pharmacokinetics work when it's released from the bloodstream. So it's complicated, but I'm going to explain it to you in a way where you will be experts of steroid pharmacokinetics by the end. So steroids works by decreasing inflammation in your body. And if you compare that to a fire in your house, if you have a fire in your house and you have a sprinkler system, you say, thank God for that sprinkler system. I don't care if there's a mess and there's water everywhere. It saved my house. The house didn't go on fire. And that's how doctors feel about steroids. They are absolutely life-saving. In acute and chronic situations, they save the patient, and they're so thankful for them because they work so quickly and so effectively. But if we return to that fire in your house, there continues to be these smoldering embers, which one has to pay attention to. And the only way that you can treat these smoldering embers of the fire from your lounge is by having the sprinkler system go off every single day at about 10 o'clock in the morning. So you have the sprinklers go off every single day, and then it really starts to cause some damage. Then you're running around with mops and towels, and the more this goes on, the floor starts to buckle, the paint starts to chip, it starts to damage your rug. And this is the damage that steroids also does. If you just administer it day after day, you really start to have to manage a lot of a big mess, lots of toxicity. So over time, doctors, after giving chronic steroids, are running around with their mops and their towels, and they're attending to all of the various toxicities that steroids cause. Iridex delivers the steroid in such a way that it's small doses but continuous doses. So it's like adding just small amounts of water to those embers. So it just keeps it at bay without causing the big mess that a sprinkler system would cause if it dispensed huge amounts of water every day in your house. So when we look at the management of AT, there are no approved drugs to date for AT, as you well know, and physicians manage the immunodeficiencies by optimizing vaccines, giving IVIG if necessary, treating the pulmonary infections with antibiotics and steroids. For the cancers that arise, they have to modify the treatment because they can't give radiation. They have to reduce some of the chemotherapy that they give. So it's a challenge, but it's really supportive care and using the drugs that have been commercially available for many years. how has corticosteroids evolved as having a role in AT? Well, through parents. Parents know their children with AT better than any clinician, and you all know that. And a parent noticed that when their child received betamethasone for a pulmonary infection, that their neurological symptoms improved. So as a result of that, there were various studies done with a corticosteroid called betamethasone, which is very similar to dexamethasone, which we use in Aradex. And there was some improvement, but unfortunately, there was so much toxicity that it never really became the standard of care for AT. They just could not administer the steroids in a way that avoided these toxicities. And when we look at toxicities of steroids, you can see those that are physically represented through cushingoid appearance, that swollen moon face, increased appetite, GI upset, hirsutism, which is hair on your face where you really don't want it, acne, and then you can objectively measure it through suppression of the HPA axis and adrenal suppression, decreased bone mineral density, weight gain. It impacts growth retardation, causes cataracts. It's really a very problematic drug, but life-saving at the same time, so it's a double-edged sword. In pediatrics, it's particularly complicated because it suppresses growth, it causes osteoporosis, it delays puberty, causes excess weight gain, hyperglycemia, and immune suppression. So it's not pleasant to give to children, certainly chronically. So I'll review with you the data from our previous study in AT called the ATEST study. This was the largest study ever conducted in AT, and it enrolled 175 patients. And patients were randomized to receive either the high dose of Aradex or the low dose of Aradex or placebo. And it went for about 12 months. And this is, when we look at efficacy of drugs, we determine in advance the primary endpoint by which we're going to measure efficacy. And that was through a neurological assessment. And to demonstrate that a drug is effective, you need a p-value of about 0.05. And you can see that the study did not meet that endpoint. It was higher than that. So it did not meet its primary endpoint to demonstrate that it was effective, against placebo, for the neurological symptoms. But I think that the study was done during COVID, and I think COVID really adversely impacted this clinical trial because the children had to come to the hospital to receive their infusions, and this resulted in a lot of delay of therapy and the children not receiving the drug as they were supposed to per protocol. But when we look at, the data in those children between the ages of 6 and 9, where we know neurological deterioration is most pronounced, we did see some benefit. And you can see that the p-value is much lower. And there was some work done by Dr. Letterman's colleague, Dr. Crawford at Hopkins, that clearly demonstrated neurological deterioration is most pronounced in that age group, and that's where we saw the greatest treatment effect. So when we measured that, we did it by a neurological assessment called the ICARS. And there were various ways that we looked and chopped the data, but regardless, we saw a treatment effect, whether we looked at the full ICARS or just that part of the neurological scale that focused primarily on gait and posture. We saw, a little bit more of a response. So what we were really reassured by is the long-term safety. We saw none of the typical steroid-related toxicity that you see with conventional steroids. So the cushingoid features, the hirsutism, the obesity, none of that. We didn't see any of it. No hypertension, hyperglycemia, cataracts. It wasn't reported. And in terms of adrenal insufficiency, which is very common with steroids, most children after receiving 2 weeks of steroids will develop adrenal insufficiency. We just had one child that had a cortisol level that was low enough that we could define it as such. And the infections were about comparable, slightly more on the Aradex arm, 49% versus 42% in placebo. But pruritus, which is itching, is something that absolutely is a result of IV dexamethasone. And we could see in about 11% of patients pruritus or itching pretty much centered to the perineum, which is really quite a unique side effect. So the NEAT study is the clinical trial that's currently underway. And it's a study in 86 patients. The children are randomized to receive the high-dose Aradex from the previous study versus placebo. 86 children in the 6 to 9-year-old age group, and 20 children greater than the age of 10 will be enrolled. And it's a 6-month study, a 30-day screening period, 6 months of treatment, followed by a 30-day follow-up. And we learned a lot of lessons from the previous trial that we implemented into this trial. We're exclusively focused on those children who are between the ages of 6 and 9. We're enrolling children greater than 10, but that's where we think we're going to see our efficacy signal, so that's where our primary endpoint for the study will be. Thank God there was no pandemic, so the study was conducted in a very rigorous and robust way, and all of the parents were able to return to their visits on time. And it's complicated, but we used the neurologist at the bedside as the primary person to evaluate the response. And all patients who complete the NEAT trial are eligible to roll over into our open label extension study. And to date, all the children who have completed the NEAT protocol have elected to roll over, which is a very good sign, we think. We're actively pursuing solutions so that children can get therapy closer to home, because we know it's a burden to have to come into the clinical center to receive treatment, particularly in very large countries. Children can travel. There's twins in Poland that travel 700 kilometers every month to receive their infusion. So we're doing whatever we can to get access closer to home. And then we're going to add another 12 months to that study. So we're going to allow children to be treated in this open label extension for 24 months. These are the centers that are participating in the study. We have 20 centers that are participating in the study in the EU, the UK, and the US. And this is our current enrollment curve. You can see that we had a little bit of a slow start, but enrollment really ramped up here towards the end. And the goal is to enroll 86 children between the ages of 6 and 9. And to date, we've enrolled 78. We have maybe 4 or 5 that we've been identified that we're going to bring in for screening. And then in the greater than 10-year-old population, we've enrolled 21. So that cohort is full. We will close enrollment definitively by the 15th of July. So we're hoping to get just a few more patients in so we can meet that goal of 86 subjects. But the data integrity of the study has been excellent so far. The screen fail rate is relatively low. We've only had 2 children prematurely discontinue from the study, which is great. Less than 1% of children have missed their doses. 93% of the doses were within the study window, and 100% of the children elected to roll over. So we feel very confident in the integrity of the data. And then these are the timelines. We will close enrollment on the 15th of July. Hopefully, we'll have top-line data in the beginning of 2026. And if those data are positive, we will submit to the FDA and EMA the second half of 2026. And then in terms of platform expansion, where do we go from here? Well, probably every specialty in medicine has the requirement for either acute or chronic steroids, so we could be developing this for the rest of our natural lives. But we're going to focus on rare disease for now, and since we have a lot of experience in pediatric neurology, we're going to study Duchenne muscular dystrophy as our next indication. So thank you very much. And for all of the parents out there who participated in our study, we are so grateful to all of you for your contributions. And it was a pleasure to meet many of you last night and learn more about your journey and, the struggles that you have and what's most important to you in the care of your children with AT. So thank you for that.